Good morning and welcome to our monthly live broadcast of endovascular cases here from Mount Sinai Hospital in New York City. I'm your moderator and host for the day, Vishal Kapoor, and we're going to be going to the cath lab to see our endovascular cases for this month. I'll be joining soon with my co-host, Dr. Raman Sharma, who just walked in. Welcome, Raman. Before we go to another interesting and exciting case, just to remind you and invite you to our annual New York Endovascular Summit, which is scheduled this year from September 24th to 26th. It's an exciting 3-day gala of endovascular events where we cover all the spectrum of our endovascular techniques, from starting with the aortic boot camp and an endovascular fellows course. This year we have special emphasis on venous and PE symposium, in addition to our peripheral arterial disease, critical limb ischemia, and the podiatry summit. So it's a great summit to come to our small town of New York City, enjoy some education, move the city around, and then of course interact with all the international faculties from around the world, as well as see some exciting live cases, have discussions and debates to discuss the future of endovascular for the endovascular cases. So before further ado, you can also visit our website, nyebs.org, for further details, including registrations. And without further ado, morning, PK.
Vishal, and thanks for the nice introduction. We were complimenting your tie and how nice you look today.
Man, I just walked in and I was like, how is nobody going to say anything about this? Love it.
That was the discussion, Roman. I just was shocked that the tie was so lively.
I'm surprised that they're all in the same apartment.
Exactly. So anyway, welcome to everyone. I'd like to introduce our faculty here for this live case. Of course, we've got Karthik Guja, who's our director of Mount Sinai South Nassau, our esteemed colleague, Dr. Jit Rao from vascular surgery, who's been part of this. It's actually now is really an integral part of our CCC live cases. Appreciate all he does. He's the director of vascular surgery research and obviously involved with all the teaching for all the fellows, regardless of specialty. And then we've got Ray Lascano, who's our interventional nurse practitioner. Michael A., as we love to call him. Michael is graduating in a couple of days, actually, and it's nice that he's with us, and of course part of our endovascular fellowship team. And of course, we would not be anything without our excellent nurses here, as well as our techs, and we're ready to go. We have Denisa, Reka, and we have Damien today. I believe that's it, right? Yeah. Okay, I got everybody. And I also would like to really thank BroadMed for their incredible support. They're obviously the people who make this happen and are able to accommodate all the difficult things we ask for on the fly, like today. We changed our AV system twice, and they were so accommodative. And again, without their support, we'll never be able to get this done. So we've got a very interesting case, Raman and Vishal, today, and I just want to talk a little bit about that and then get your thoughts, as well as then we have Ajit here to give his surgical as well as endovascular thoughts. Mike?
Sure. Can we get the slides up, please? Good morning, everyone. So we have an 85-year-old gentleman, history with lifestyle-limiting claudication, left greater than right. He's progressed to ischemic rest pain despite a structured exercise program and optimal medical therapy. So past medical history, you can see all the comorbid conditions: hypertension, heart failure, coronary disease with multiple PCIs, COPD, venous insufficiency, and diabetes. He was a former smoker, 105-pack-year smoker, no other substances utilized. And you can see his long list of medications there. He's on DAPT, Rosuvastatin, Zetia, all the good GDMC for heart failure and PAD. So this is his arterial ultrasound. You can see very high velocities in the CFA and the SFA on the left side specifically, indicating some pretty significant disease, and some high velocities in the right SFA. But we're going to focus on the left side here. So this is his angiogram from the last time. You can see a nice big calcified chunk there in the distal CFA and the prox SFA.
Okay.
The last one's not playing. We'll show you the run. We'll show you the runoff. What about
Yes,
there it goes?
right
There it goes. There it goes. Okay. So whatever reason, it's not really showing up well, but we took our diagnostic shots. There it is. Okay, good. So he has about 3 vessel runoff, but you'll see the runoff today. It's gotten quite worse. So anyway, with that, I'm going to ask Michael to stop there. We just want to go over the angio here. Maybe Karthik can go over it. Can you go live to the angio guys here? And then Karthik, you can go over what we did. So Raman, Vishal, we decided to go with an 8 French hit. The first thing Ajit asked was why 8 French, and I think it's a great question. I think based on our vessel prep and destination therapy, we could have gone with a smaller one, but since it's a live case, we want to be able to shoot around and demonstrate, we decided to go with an 8 French. You can see the common femoral here.
Yeah.
Karthik?
So here again, the SFA has the same calcified chunk on the right side. The patent iliacs stents on both sides. I think once, as Mike was saying, the calcified chunk here extends probably from almost distal CFA down to the proximal SFA. I think 2 small branches of the profunda, but the major profunda is right where the calcified chunk is. It's pretty much around 90% occlusiveness. I think when we do IVUS, I think we're going to appreciate it even more. As the previous angiograms Mike was telling about, some moderate disease in the mid SFA, and the
flow is
like extremely slow, and then
good.
And you can see the flow pattern even in the vessels. We had 3 vessel runoff. I mean, here it looks almost like 1.5. So definitely, I don't know if it's a flow pattern which has gotten worse and
The lesion.
like that, but
Very
yeah.
obstructive.
Yeah.
Yeah, very, very obstructive lesion. Yeah.
But you can see these are very delayed cines, guys, and you can see that the flow is really bad in the posterior tibial,
Yep.
slowly coming down. But I mean, he has monophasic Doppler signals in the foot,
Yep.
and obviously very, very symptomatic.
Yeah. Looks like
Yeah.
it's a AT and peroneal. The PT is occluded.
So, I mean, the controversy here and the reason why we wanted to present it is, first of all, is common femoral disease, but, here, sparing the large branch of the profunda, it's just below that. There's a small branch of the profunda that comes off, as you can see in this still shot here. So the question is here, can this be handled endovascularly? Second is, if you choose to handle it endovascularly, what is the therapy that you'd like to do? Is this a good case for, say, lithotripsy, good case for serenation, followed by therapy or a directional atherectomy, or is it a orbital atherectomy or jet stream atherectomy case? So that's kind of why we presented it, and also to look at what is our destination therapy finally in this particular thing, and what does the data suggest if we decide to do it endovascularly. So that's kind of the learning objectives of why we wanted to present this case. And I wanted to just turn it to, before we get comments from both Raman and Vishal, Dr. Kapoor and Dr. Sharma, let's ask Dr. Rao what he thinks in terms of this and how we would handle it as a surgeon himself if this came about.
Yeah, I mean, I think this is a great case. I'll start off by saying I don't think all common femoral lesions are the same, right? The ones that are more proximal, I think, can be a little bit, easier and maybe more straightforward to treat. But once you're getting down to the bifurcation, like in this case, I think those are the challenging ones for endo, because you really don't want to, the last thing you want to do is compromise the profunda. So this will be a tough case, and then especially with all that calcium. So I think that's number one when I'm thinking endo versus open, is just how tough it would be with the common femoral lesion. In general, I think, as a surgeon, common femoral, and I know this is debates, at every one of our conferences almost is, but I do think common femoral, in general, surgery, should be the gold standard, just because I do think it is a very durable option. That being said, there are patients I definitely wouldn't want to operate on. So patients that have had hostile groins, maybe a re-op groin, you guys, I'm sure have all seen that if you treat PAD, but like this very scarring groin where you can't even get the micro in, it's going to be a very hard dissection, very high risk for wound complications. And then patients that are sick, like this patient that has CHF and multiple comorbidities where, I don't really want to put them under more heavier sedation. So I think this is a good endovascular case, although I do think it will be challenging given the location and degree of calcium.
So go ahead, guys. I'm sorry.
Yeah,
I just want to say, Raman, before you start, we're going to do IVUS so you guys can watch the IVUS.
Yeah, I mean, to be honest, like the answer is going to come from the IVUS. I think it's CFA, SFA profunda disease discussion is one that is very, very common. My question really is how much of this disease is truly located in the CFA.
Common femoral. Yeah.
And I
Yeah.
feel, just based off the angio, even if there is a little lumpy bumpy in the CFA, for this patient, the majority of the disease, the inflow, even if there is a little bit of disease in the CFA, may just be okay just to leave it alone, focus on the SFA. And I think we'll really see, as far as the IVUS, where exactly the majority of this disease is. And unless my eyes deceive me, it seems as though the majority is in
Right.
the proximal SFA.
I think that's a great point, and I think one thing which we underestimate and which we actually demonstrate in this case is having a surgical aspect, or having a what we call the vascular team approach, especially in patients who have CFA disease. I mean, I know this looks like Raman talk about physiologically CFA, but anatomically SFA with some profunda. But having a vascular surgeons involved where there is an extensive CFA disease is always great, because I'm sure Mike A is going to talk about data about endarterectomy and atherectomies and DCBs, everything. But I think getting a surgeon's perspectives to make sure the profunda, which is your lifeline in this case, is not compromised while we are having focus on the SFA part. So it's a great case to show how we can manage endovascularly, but I will have a surgical backup as well.
All right, so we got an 018 IVUS down. Record, guys. And I'm just going to pull back. How is it showing up there? I can't see how it is on your screen.
Excellent.
Okay,
it's
good. I just want to make sure. Okay, here we come. So there,
Second nugget.
that's the second nugget right there you saw. And yeah, very, very
Subtotal,
inclusive.
yes, yeah.
So I think
A little tight.
yeah, we're gonna go over the arc
It's
of
like a blink
calcium.
of an eye.
One of the studies that was done was the jet calcium study that Mike will go over, and here's another one. So you can see it's completely around the IVUS catheter, and then the arc of calcium. There it is. Look at that.
Right,
It's
that's
just
beautiful.
yeah. And then I'm gonna see where the profunda comes off. And
Still
there,
CFA, yeah.
there's still CFA. Anybody see
There's
the
calcium there,
profunda?
too.
Not yet.
Right.
Not yet. Not yet.
I think
There it is. The shadow
we
of the
passed it.
calcium.
we passed
Yeah,
it.
we passed
I
it.
think there was just a lot of calcium
The
shadowing.
calcium cover the profunda ostium.
So right now, looking at that, Ajit.
Yeah.
Question: you did mention not all CFAs are obviously created lesion patient characteristics.
Yeah.
Does lesion characteristics play a role? I mean, in terms of, I mean, are you looking for any particular lesion or location of lesion that you would say, hey, I'd rather do an endarterectomy than this? For me, angiographically, again, let me show you the angiogram one more time. When you look at this, you can see here that we'll show this one. That looks like the lesion is just below the takeoff of the large profunda, and that we should be able to get away without actually messing up the ostium of that profunda or embolizing into the profunda. So that's part of the reason why we felt like, hey, you know what, that this could be endovascularly managed. And before we get to the therapy, I mean, does that play a role? Because I know that, there are a lot of people use the Medina classification that have become famous in the coronaries for common femoral disease. Do you do those kind of things?
I'm not as sophisticated as you, so I don't use the Medina classification, but I do look at the location. So I think you can be fooled by this lesion, because I do agree with all of you that it's mostly in the SFA, but it's definitely extending into the common femoral. If you were to open this up, you just see this chunk of calcium going up into the common femoral. So you can be fooled because you think you're treating an SFA lesion, but you're really treating common here too. And so this is the lesion I think that's the highest risk for endo. So you definitely picked a tough one, because if you have any shift in that plaque, especially with all that calcium, you're going to just push against the origin of the profunda, which also already looks a little diseased.
It does.
Yeah.
What we could also do is take the wire, put it down into the profunda, and do a pullback from the proximal profunda into the CFA, because we didn't really get a good proper visualization of that bifurcation.
Yeah.
The only question here, Raman, is what we did, just to tell you, just to save time, obviously, because remember last time the case dragged on. What we did was we already put a filter down, and we'll talk a little bit about. Yeah, I just want to let you know. I mean, we have an 8 French. We could probably side by side wire. You want to do that?
We can side by side wire.
Yeah, give us a run through.
I mean, the idea, like Ajit talked about, is, I mean, the profunda does have disease extension. It's technically non-obstructive and non-significant, but definitely there is a component of disease that's extending into the profunda as well. So you just have to be cognizant of the fact when you're treating your SFAs, is like we talked about, whether we impinge the ostium of the profunda because of, let's say, we're doing a PTA versus embolization.
I think that, I think that's definitely true, but we chose to do, the fellows know this, that every decision you make, every question you ask, there has to be a specific question you're trying to ask, and you have to get that answer. And with this IVUS, we wanted to see, was there calcium that was extending into the true bifurcation of the profunda and into the CFA. And with this IVUS, because of the degree of calcification, that question was not answered.
Right.
So it's like, do we really get all the information that we really needed here?
Well, that's true. I mean, IVUS will give you, of course, the best information anatomically. But let's say we find calcified ostium of the profunda, but non-significant. Now the question really arises is, do we just treat the SFA, leave the profunda, the disease as it is, and then just watch clinically? Or now because you have disease in the technically CFA, SFA, and non-obstructive profunda, you just want to repair all together one time and be done with it surgically?
Well,
I mean, again, it's like Ajay talked about. It's a debate that happens in every conference, every session, every case, and we can just roll the dice.
Well, I think the IVUS is going to tell us a lot. I agree with Raman there. It's going to let us know a lot here. Anyway, now Ajit knows why I went with an 8 French.
Yes. Good idea.
So now
if you have access,
we've got access, and now we can go with an 8 French into the profunda. All right, so this is in the profunda. Let's go IVUS live.
Roadmap it.
Fluoro? No, we don't need roadmap. IVUS live because it won't show the IVUS. It won't show the IVUS. That's why. IVUS again live, guys. Hold on. There you go. Okay, record. And you can just give diacard when we get close. So I'm getting close now to the ostium of the profunda. I'm just letting everybody see there's the ostium right there. So, what happened?
We stopped. No, go live.
Let's go live again. Let's record again, guys. Sorry. Stop.
Recording.
Stop.
It's recording.
It's recording. Okay, we'll pull back. Sorry about that, guys. Some technical issues. So there's a little plaque, but not calcium.
Huh?
But the calcified chunk from the
correct.
Comes into
that's the origin right there.
Yeah.
There it is.
There it is. So I guess we'll have to wire protect the profunda. We'll decide. All right. So now, having decided that the profunda is involved now, so now I'm going to pull out this wire because we don't need this wire now.
So that's an interesting thing now. So the idea to wire protect, I think, is a really elegant solution to this. But now that limits some of your atherectomy
device choices.
Well, but Raman, do you think the atherectomy? Oh, that's a great point. But do you think that will plaque shift with the atherectomy or will plaque shift with the balloons?
Yeah, that's the whole point. Yeah, I think. I think the majority of the plaque shift. I mean, it depends on the atherectomy device that you choose. If you do like a 2.0 solid crown, start at the distal CFA, then technically you're going to have a few orbits that are going to be above the bifurcation to hit that chunk. Now, at that point, could a little tiny chunk go into the profunda? Yeah, maybe. But then remember, the orbital chunks are going to be much smaller.
But you're right.
Wait, hold on. Just for the sake of time, we decide we're going to do some sort of vessel prep. What do you guys choose? Karthik?
I would go for Jetstream here because of the size of the vessel. The size of the vessel looks like it's almost 7.0, and I don't think there is any atherectomy device for this calcium other than Jetstream, which can give you a good luminal gain. If you're trying to modify and get a luminal gain, I think that's where Jetstream comes. I mean, you can try CSI, but CSI is not going to give you the luminal gain of this vessel, at least.
Okay. Jet?
So for this kind of lesion, I kind of throw out everything. So I would do atherectomy and lithotripsy because I'm really trying to reduce my risk of stenting and recoil. So for this, I would do both atherectomy and lithotripsy. I use a lot of
which atherectomy?
Directional atherectomy, and I think Jetstream is also a good option.
Well, directional gives you an advantage, but you saw IVUS, it's concentric.
Calcified for directional.
So
it's very calcified for directional. It's not going to.
I'll be the odd man out. I would do a 2.0 solid crown.
Which is very reasonable.
It is reasonable.
Yeah, I think atherectomy with a little bit of aspiration here is not a bad.
Also with legit 100% with IBL.
Yeah. So I think you're right. Doing an atherectomy right at the SFA with that degree of calcification, and we know, right, when we do atherectomy, slow motions, controlled motions,
you can gain 7
we can get correct. You can get a good luminal gain and still have a minimal embolization to profunda. I think I'm not concerned while doing atherectomy. If we do it with slow motions, we should be okay with the profunda part of it. And before we start impinging on the profunda, then you can double wire when you're doing a PTA or your lithotripsy. But I think we've learned even from coronary, as you know, we do our main vessels, and even if the side branches are very occluded, the usually shutting of the side branches is very less.
I want to cut you off there and say this ain't no coronary, so let's to quote the great Jim McKinsey,
Well, Medina, you started with Medina. Don't forget about that part.
No, but that's
you started with Medina.
No. It's a classification. I didn't say that it's a similar thing. But anyway, you're right. But let's we decided to go with the jet stream here, and can we play the animation first, and then we'll talk a little bit about this device. Play the animation for the team. So for those of you, I know Jetstream's been around a long time. The adoption is varied throughout the country, but clearly there are pockets that do a lot of Jetstream. But we also believe that it has a certain role. It comes in three different devices, and we'll talk about that. Go ahead. So you can see here, as you can see, it's basically like a drill, for lack of a better word, with aspiration capacity. So this particular Boston Scientific device will go ahead and actually act as a drill and aspirate at the same time. It's over the wire. Embolization does occur as in any atherectomy device, albeit less with this particular device. And because of the aspiration capacity, it's able to handle thrombus quite well as it's got an indication for ISR as well. So it comes in two modes, blades up and blades down. Initially, we will go with the blades down mode to create a channel, followed by which we will then go with the blades up, and you can see it fans out in the back, sort of like a large fan, and then that creates a larger lumen, which is one of the big advantages of this over the orbital atherectomy. Orbital atherectomy, as we know, has a different mechanism of creating a lumen, but this is a more standard mechanism. Again, it has been studied in different lesions, and we'll go over the data very shortly, but I just wanted to show you the setup. So Ray, can you go over the setup now?
Sure.
This is Ray Lascano, who's going to show us the setup.
So the setup is pretty much pretty simple. We have the Jetstream console.
Can you go live on Ray, please?
Yeah.
1 second.
So this is the actual device that comes in the packaging, the way it is. Sterile, of course. And like I said, it comes in two packaging. One is the device itself, and then the Jetstream console. So what happens is this is just the catheter here. We set that aside, and then we hand this part to one of our techs here to kind of set it up into the Jetstream console there. So that's what we're doing right now. And then it gets attached to a IV bag that has the saline in it with
Rotaglide.
With the Rotaglide, exactly, with the Rotaglide in there. So that's what's happening. They're setting that up. And then, so before we put it in the body, we're going to have to flush it out. And we're just got to wait for them to
de-air
it and put it in.
Ray, what size is that?
This is a 2434. Yeah.
So 2434 is the largest Jetstream that's available. You have 1621, right, Ron? 1621 and 2131. Am I saying it right?
Yeah.
Yes. So we have three different styles. It really is meant up to the trifurcation. I've never really taken it below. I don't know, Ajit, have you taken it below the knee? I mean,
no, popping above.
The max. Yeah, we've never done it. I'm sure others have. A lot of doctors have a lot of experience out there. Nick Shamas is widely published on Jetstream, has done a lot of great work on this, and it's a fantastic device. So
before we put it in the body, we have to prime the catheter itself. So we got to dip the tip of the catheter into a bowl of saline, but making sure not touching the side of the bowl. And they'll press the prime button, and it'll just de-air it. Takes a little bit.
So the whole idea is, again, like in anything that goes in the body, you want to make sure there's no air into it. And if air bubbles come out, you see that little white stopcock that's on the console. Ron, if you could just kind of point to the white stopcock on the console up there.
Right up there.
That's what you use to de-air it. If it does detect a bubble, it's quite intuitive setup. Obviously, the Boston Scientific team is always available to help if it's or train your staff as well. So here, it'll actually time out once it's done. So anyway, in the meantime, as it's getting prepped up, we're going to go with Michael, who's done a wonderful presentation for us. Let's go to the presentation as we set this up. Mute the mics in the room, guys, so Michael can. We're going to go ahead and we're going to go live. Go ahead. Go ahead, Mike.
Can I get the slides? I can't see the slides.
The slides are on.
No, I can't see. Okay.
Oh, okay.
Yeah. So we'll kind of, I know we had this discussion already, but we'll touch base again about revascularization for common femoral artery disease and infra-pop disease. So these are the guidelines from 2024, which I'm sure everyone has had a chance to see already. But basically, what it says is in patients with functionally limited claudication, who haven't really responded to GDMT or structured exercise, surgical endarterectomy is reasonable, especially like we discussed, if the endovascular approaches will adversely affect the profunda. And then in patients like our patient, with similar functionally limiting claudication, haven't really responded to GDMT, and an endovascular approach may be considered in those who are at high risk for revasc, like this gentleman is. So that's a 2B, and the endarterectomy is a 2A. So this is not an all-encompassing slide, but just some data behind endarterectomy versus endovascular for common femoral artery intervention. On the right here, you can see that you see 1 year follow-up, 5 year follow-up, and 7 to 10 years, and you can see that the patency for endarterectomy at 1 year is 93%, even up to 5 years, anywhere range from 78 to 90%, and 7 to 10 years still, up to 80% patency. For endovascular, for 1 year, you have 78 to 88%, depending on what study you're looking at, and similar for 5 year patency, you have 60 to 79%. So on the left here, you see, again, not all encompassing, but some slides, some studies from 2016 to 2025. And again, I do want to point out that the intervention arm for endovascular varies in a lot of these studies. It's not homogeneous. Endarterectomy is the standard, but they compare it to stenting in the TECO trial. In cauliflower, they compare it to different endovascular approaches. And then in the Ariston study, that's where they kind of try to make it as homogeneous as they could as far as the endovascular arm, where it was atherectomy assisted endovascular. And then similarly, kind of we had discussed already, with either of these approaches, you have your risks. So from a surgical standpoint, there's always risk for wound infection, surgical takeback or revision. You can see that's about 8 to 10%. Versus in a longer hospital stay versus in the endovascular arm, you have a shorter hospital stay, less risk for infection and lymphatic leak, but you also get, that comes at the cost of patency, as we saw from the prior slide. So I did want to touch on some trials. So this is the TECO trial, where they basically compared stenting versus surgery for de novo common femoral artery stenosis. On the left, you can see the baseline angiographic and interventional data. The surgical techniques, endarterectomy was the major one there, and then from a standpoint of stenting, they use both self-expanding stents and balloon expandable stents. And on the right here, you can see 4 different tables, where on the top left they compared survival, the top right was freedom from TLR, bottom left was TER and patency on the bottom right. And you can see there really wasn't a significant difference between surgery and stenting going out to 2 years. So at least on the TECO trial, the patency was similar going out to 2 years. The next trial I wanted to discuss was cauliflower. So this looked at 1 year outcomes for basically endarterectomy versus endovascular therapy for common femoral artery lesions. They ended up doing a propensity match where they matched patients, to simulate as best as they could to make it an RCT. On the left, you can see patency. So in this trial, surgery actually did better, looking out up to 1 year as far as patency goes, where endarterectomy had a 97% patency and endovascular therapy had an 82% patency. And then the top right, they basically looked at subgroup analyses. And you can see for device used, it was POBA stent or DCB. Stent had the best outcome with the lowest hazard ratio compared to thromboendarterectomy. And similarly with residual stenosis, there was more residual stenosis in the endovascular arm with greater than 25%. What they also looked at, actually, they did an interaction analysis, and in patients who are non-ambulatory, it actually attenuated the hazard ratio, meaning that for non-ambulatory patients, endovascular therapy was equivalent to endarterectomy. Looking at the other side, similar to our patient where there was nodular calcium, endarterectomy was actually better. But again, you always have to take the patient as a whole into account and their surgical risk. So, a lot of the trials that I showed early on didn't really have any amount of any really plaque modification. So before I move on to the next study I wanted to discuss, I just wanted to mention some plaque modification options. So, we have on the bottom left, you have the orbital atherectomy with the Diamondback. The top right, you see lithotripsy. The one in the middle with the orange is directional atherectomy, and the one on the bottom right is the jet stream atherectomy. So three different types of atherectomy and shockwave are typically things that we can use for plaque modification, especially when it comes to calcium. So this is the other trial I wanted to discuss. Very busy slide, but it's called Ariston, multi-center study, where they looked at atherectomy-assisted endovascular therapy versus open repair for common femoral artery disease. And you can see, for the most part, the patient demographics were fairly similar across. They had 213 patients who underwent endo, 613 patients who underwent open. And lesion characteristics, I did want to point out, this study didn't just, cherry pick very simple lesions. So you can see where the brackets are, about 70% of the lesions were common femoral artery with bifurcation involvement, similar to our case here, and also involvement of the external iliac with CFA and femoral bifurcation involvement. So again, a very busy slide, but some of the things I wanted to point out. So in 83% of the endo patients, they used some sort of atherectomy, and then the destination therapy was DCB in majority of the patients. And then they did need to do some stent placement in the CFA, which is about 22 patients. Near the bottom in red, you can see the 30-day complications in total, and you can see that there was a fairly significant difference between 30-day complications when it came to endo versus the open approach. And similar to length of hospital stay, which I had alluded to prior, patients who undergo surgery will be in the hospital longer versus someone with an endo first approach. And then near the bottom where they looked at Mason male at 30 days, there really wasn't a significant difference between the two. And then, so similarly in this study, which I think is great, is they also did a matching to, again, try and take as much bias as they could out of the patients. So you can see that, the top left is all-cause mortality, top right all-cause mortality and claudication. The bottom left was CLTI, so they had patients who were both claudicants and with CLTI. And the bottom right was all-cause mortality in patients in 70 years. So the light blue is the endo, the dark blue is the open. And you can see that, there was really no significant difference in all-cause mortality in claudication or in general. And then patients with CLTI actually tended to do better with an endo-first approach as far as survival probability. And similarly, patients who are older, which makes sense, older patients tended to do better with an endo-first approach versus open. And then this just looks at amputation-free survival, which again, similarly, in all patients, claudicants and patients with CLTI. And again, you see the p-values down, 0.39, 0.5, and 0.85. There really wasn't a significant difference going out to 4 years as far as amputation, whether open versus endo. So this is a very involved trial. So just some key points. Largest multi-center study that described contemporary strategies, atherectomy. Both open endovascular are safe and show comparable results in terms of freedom from TLR and success with sustained improvement. And like I mentioned, these weren't cherry-picked lesions. They, 70% of the lesions were considered complex with either bifurcation involvement or external iliac plus bifurcation involvement. And, the atherectomy-assisted therapy in combination with DCB show lower bailout stent rates, which is the preferred approach. You don't want to leave anything behind, especially in the CFA. So moving on to IVL, this is a registry study from 2024 that looked at 163 patients with CFA disease primarily, and this looked at IVL use in a real-world setting. And you can see on the right there, pre-procedure, the diameter of stenosis was about 75, post-IVL was about 30%. So this is just showing that IVL can work as far as reducing the stenosis in real-life patients. So just another, some more data as far as plaque modification that we have available. And just some of the characteristics, angiographically and the outcomes there. You see, I did want to point out at the bottom there, 36% of patients had eccentric calcium versus concentric, and then 95% patients had moderate to severe calcification. And on the far right, you can again see the MLD, which the diameter increased from 1.6 to 4.5 post IVL. Another observational study, this is again for IVL, called the Festival. and this looked out at the patency for 2 years. And on the left you see the baseline characteristics. On the right you can see the patency for CLTI and for claudicants was fairly good looking out as far as 2 years. And I did want to mention that about 22 of these cases were complete occlusions of the CFA. So these weren't 50%, 60% lesions. Some of these were also CTOs. So, there was also a systematic review with a meta-analysis done in 2025 that looked at all the atherectomy devices and IVL. So pretty thorough study. You can see on the top left, 10 plus studies for atherectomy, and on the bottom 3 plus studies for IVL. And again, this is just showing, very busy slide, basically just showing the intervention that was used, the atherectomy or IVL device, the balloon that was used, bailout stenting, and whether an embolic protection device was used. And you can see for atherectomy, they use all different kinds. They use directional, rotational atherectomy, and orbital. So it's a pretty good mix of different atherectomy devices. So basically, what this slide is showing is that both atherectomy and IVL showed very good outcomes. So the top one is the freedom from TLR. So 90% of patients did well without needing intervention from an atherectomy standpoint when you pool all of these studies together. And similar for IVL. And the bottom right is just limb salvage. And again, similarly, you can see that 97% of patients with atherectomy didn't require any reintervention, and 95% of IVL didn't really require any need for a reintervention. And there's just a table summarizing. So we discussed the freedom from TLR and limb salvage, but also technical success was good for both atherectomy and IVL, and bailout stenting was fairly low in both the plaque modification techniques used. Interestingly enough, there was higher perioperative complications from an IVL standpoint compared to atherectomy. But this, this meta-analysis systematic review basically showed that atherectomy and IVL both, perform very well when it comes to CFA disease. So I did want to just touch base on some jet stream studies. So the first is the jet calcium study. So this study basically showed jet stream's ability to create significant luminal gain in severe and moderate calcium as measured by IVUS. The patient characteristics, you can see those 55 patients, over half of them were diabetics. Almost 2/3 had severe calcium, and over 90% had superficial calcium that was greater than 5 millimeters in length. And on the right, you can see pre-IVUS and post-IVUS, or pre-atherectomy and post. You can see a lumen area from 6.6 to 10. So there's 86% lumen gain was directly attributed to calcium reduction just based off jet stream alone. The next study I want to touch base with is the JET registry. So this study basically demonstrated high freedom from TLR rate at 12 months and a low embolization rate for patients. So 241 patients, 258 lesions. Again, good percentage of them were diabetics. 30% were complete occlusions. 90% had angiographic calcium, and about half of these were grade 3 and grade 4 calcium. And you can see the clinical results, so 77% patency, 81% freedom from TLR, and improvement in both the Rutherford category and ABI improvement. And then the last one I wanted to discuss is the JET SCE. So this looked at DCB as a destination therapy. So this showed that TLR rate was significantly reduced when you used atherectomy with DCB compared to atherectomy with just PTA. And this went out to 18 months. And again, 53% diabetics, 26% with CTOs, and this showed 91% patency, freedom from TLR when you compared atherectomy to DCB with DCB versus atherectomy to just PTA, which is 63.7%. And this slide is just showing, the atherectomy system. I know we briefly discussed it, but it's good for calcium, plaque, thrombus is what they show. You can see the front cutting blades there. There's expandable blades just behind that, and there's an active aspiration port as well. And the way that, similar to the coronaries with Rota, it does differential cutting, so it deflects away from healthy tissue and primarily cuts towards calcium. I just have the jet stream.
Mic on, please. All right. Well, I think I don't know if you guys can hear me yet.
Yes, we're good.
Okay, fantastic. So, Michael, great job. Great presentation. I think you guys saw on the side what we did. So we took the jet stream catheter, the 2434 down over the wire, and then we did 2 passes, blades up and blades down, multiple on the upper one and on the lower one. I just want to demonstrate our technique once for you guys here. So we're going to go, give me the roadmap, right? We'll just do a quick roadmap.
You want to do blades up?
No, first we'll just do one, just blade down. So remember, initially in these kind of lesions, you always want to do blades down. So we're just going to get this a little bit lower. So this blades down. And right now, it's basically a pecking motion, very small pecking motion like that, right? All the way down. And then our blades up. Blades up. Go ahead. On. And you hear that specific dot and that little beep. And that beep will really tell you that it's now this. The blades are up. The nice part is it has differential cutting. And I think that's very important because differential cutting will not allow it to hurt a regular healthy tissue. One of the people who invented the Jetstream device, Ted, used to put it on his tongue and demonstrate to everybody that it would not hurt his tongue because his tongue is healthy, according to him. But anyway, but the bottom line is it's a very, very safe device to use. And I shout out to Ted there. I just wanted to show the demonstration. So now you can see by the angio that Karthik and I and Ajit took. We'll take another one now. Ready?
Yeah, you want to pull back?
Just inject. It's okay. You can see here that you see how you still have that eccentric calcium. So you're not able to direct it. The advantage with directional atherectomy, like Ajit was saying, we're able to direct it. So now we're just going to IVUS, and then you guys let us know what you think we should do. So we're going to walk this out. So always walk out on Rex, right? And it's an over-the-wire system. And as Karthik will walk out, I usually watch my filter. Because everything else seems to be very stable in this situation. So we go down, we keep an eye on the filter, and look at the embolization there. So it's very important, right? That we're careful. Yeah. So again, that's another reason to use the filter. Rex,
you're in the sheath.
Rex.
You're in the sheath.
Always on Rex, and then as you come out, there, it's out now. Now we got a column of contrast for the embolization, and that's one of the reasons. So now we can either take the jet stream down and try to aspirate that. We can do that, or we can go with a traditional aspiration device. But these are some of the challenges what we're dealing with. So first, let me IVUS up top. We're anticoagulated with the Angiomax, so I'm not too worried about any thrombus formation. So why don't we set up the thrombectomy device, guys?
So there's actually a question that was put up by the audience, which is pretty apt. Asking if there is concern about compromising the profunda, why not take a wire and filter and protect the profunda? And this is why we choose to protect the SFA, because the majority of the the distal embolization will actually go into the SFA. The profunda is obviously a problem, and it goes into the case planning. And,
record, guys.
How we choose to
show us the IVUS on the screen
and our adjunctive therapy, but the
IVUS on the screen,
problem
Ray?
would be if we lose the target vessel.
100%, I agree.
So you can see here we've really modified the plaque quite well distally. Look at that. So very nice lumen there. And then just like Dr. Akiko showed in her jet calcium study, that again you can see very nice modification of the plaque all the way up to the common femoral. We have a nice lumen. So now the question is, I say, what would you guys do? Would you worry about the thrombus now, or would you deal with this? And the question is, would you do adjunctive therapy here with another calcium modification, or would you just balloon it and be done with this? So I'll take you another view just so you guys can see this.
Liver around 8 inch.
Yeah.
So I think you. Oh, go ahead.
Go ahead. I mean, go. No, you go first.
Yeah, I was gonna say that.
I was gonna say.
It depends how much luminal gain you got. We did get a good amount, but it still looks like 50% or more.
50% or more.
So I think if you really wanted to get the maximum amount of luminal gain and avoid stenting in this area, at the expense of cost, I guess lithotripsy might not be a bad idea because it still looks.
I mean, we got a pretty good lumen there. I agree with you. The only question is avoiding dissection. And we know that obviously with both Jetstream as well as with lithotripsy, we avoid dissection. Would you guys go with a cheaper alternative such as a Serenator?
I think, I mean, my only thing, like you rightly said, is the definitive therapy. If you've already made up your mind in a way some people do that I'm going to stent it because the degree of calcification, the patency, using a drug-eluting stent, then I would probably go the cheaper way, do a PTA, see if there's luminal gain. If there is, put a stent in and we're done. But if you're trying to avoid stenting and with such a significant heavy calcification, even though we've had plaque modification, then lithotripsy is a good option to try to decrease the chances of stenting and just using a drug-coated balloon technology and getting away with it. So I think that also plays a part in it. And like you rightly said, the atherectomy did give us decent luminal gain. So you could go either ways. You can start with a cheaper version, do a PTA or a cutting balloon, a little bit more expensive. You get gain, you do your DCB or stenting, whichever way you want to go. But if it doesn't open up with your regular PTA balloon, then lithotripsy is always there. But again,
and there's definitely a tight lesion still there.
Correct.
Yeah.
Yes.
Right,
Especially eccentric now.
Dude, right there, guys. You okay with that? Are you okay with the location?
I think location
We decided to go lithotripsy, Raman and Vishal, because number one, it's reimbursed. We're able to get reimbursement for it. Number two, we chose the shockwave because we're waiting on the seismic to get to arrive. I know that Boston is rolling it out slowly, and we're hopeful to get it soon. Obviously, there are multiple choices.
No, it's not on.
But are you okay with the position of the lithotripsy balloon across the profunda? You would go down.
So what size? 7.0?
7.0.
7.0.
What do you think?
I think in this case you have to go across the profunda because the calcium is across it.
Yeah,
so
I would go up here.
maybe.
So just a question, Vishal. You were part of our seismic study. You enrolled the most patients here for the seismic. Any thoughts on the differences between the seismic balloon as well as the shockwave balloon?
I think it's mainly about the emitters part of it. The shock wave, the intensity is maximum in the central emitter. So that's where positions like this, where you want to just
Go for it.
Park it right at the bifurcation or right at the ostium, you can't do it. You have to, in order to get the maximum gain, you have to come back to a normal healing segment, which might compromise the profunda in this case, which is unlikely, but still though. I think that's one of those limitations with the shock wave part of it. But otherwise, the devices, the data is very convincing. Both ends are doing
pull back a little bit,
primary, or as a part of adjunctive therapy to go into your primary mode of treatment. So yeah, I mean, that's the only issue with it.
Yeah, well, what about the data? I know you can't compare data, and as a scientific person, you don't want to compare data. There is a little difference in the data, but again, I think it all shows that lithotripsy devices, as a class and as a family, they seem to work very, very well. And obviously, as everything pans out, we'll know as we go forward how that looks.
So
my prayers is that we don't dissect this. Let's see.
Correct. I mean, the main focus of lithotripsy is causing major type C, type D dissections, which both the data suggest is significant as compared to PT as well. And I think, like you rightly said, your goal is to make sure there's not extensive dissection. So I think that's where you're adding lithotripsy as one of the options in this case is a very good decision. So, but let's see what happens.
And how are you sizing this?
Yeah, we sized it as 7 to the common femoral. I'm concerned about the distal SFA will dissect here. I hope it doesn't. I think with the,
size mismatch.
I mean, Ramani showed us with Serenator that the dissections are very, very low. He's used a lot of Serenator in our lab, and clearly the technique seems to work in this kind of case. That's why I kind of opted towards going towards that. But, and even the data with Serenator again shows dissection rates are very low, and, obviously the cost is favorable. But let's watch the distal wire again, guys. I'm going to go to the distal because even though Vishal's not here, he's here in spirit. See, oh, boy, the wire came back. See, that's what I'm saying. This wire is really...
Okay.
I hope it didn't dissect. Watch the wire. Push the wire, please.
Let's see the wire.
The wire's fine. We're just push the wire forward. Thank you. That's good. That's fine. That's fine. It's nothing gonna happen. Don't worry. Yeah, I just don't.
It's not that
the filter should not move because when the filter moves, it'll clearly it'll defeat the purpose of what we're dealing with. Okay, let's get a picture, Ray. Ready? DSA. Inject.
Yeah, I was going to say, I like the idea of being wary of causing dissections and so on and so forth, but I will be very surprised leaving this particular lesion without some scaffold.
Yeah, I would. I agree with you. I mean, it's a good area to stent it. We can park it right at the not cover up profunda and get good results. I mean, I agree with you.
All right, let's see what's going on here.
Bleeding on DCB, I'm
Ready?
not sure. I mean, the chances of recent with this
Degree of
degree of
distance.
calcification is so high. Giving some scaffold is always a
We want to
good
see
option.
the distal
And we know, right? We're going to put a short
hope we
stent,
didn't
longer
distract. Let's
stents,
see, what
more
do you
ISR.
I don't
This
think so.
will probably be like a
How
60.
big is the
Where you
face?
want to extend
Besides
maybe
it to the
five.
SFA, no, not to the
happy.
common.
I mean, I
So
think that.
Raman, look at that. Looks pretty good. We're gonna IVUS again. Let's get a DCB, guys.
Oh, yeah. Oh, okay.
I would definitely just put some drug on there and leave it alone.
Let's get the
As long
IVUS here.
7-0 DCB.
So we're gonna get a.
7-0.
Let's IVUS size the DCB because
7-0
DCB
DCB.
can dissect.
7-0.
Okay, so the consensus right now is that the majority of you guys are thinking DCB over some metal.
The metal, I think that's why IVUS is going to help us here. If we feel like there is a lot of dissection plane, then yes, I think stenting. But I think the lesion extends into the common femoral, no?
Yeah, you can see it is.
I think you can see it is now. Now it's pretty clear.
I mean, it's very clear. Yeah.
Yeah. So I think stenting it, you have to stent across the profunda. The question is, do we really want to stent across the profunda? Can we get away without stenting it?
Okay. IVUS
That's
live,
what IVUS
guys.
is going to show us.
No, I need to see it here. Okay, thank you. Record.
Stent to the bifurcation and DCB above.
Thanks, man.
It's very good.
Got a big
Very
lumen
good.
now.
Big lumen now. Right there, at least it's good.
Common and proximal.
Wow,
Very good.
nice lumen.
Yeah, and if it looks good on IVUS,
Hold on,
then
what
it,
about this area right here?
But that's where the haziness is.
No, it's good. It's a good lumen, though.
It's a good lumen.
It's a good lumen. Even there, it's eccentric, but a good lumen. And there's your
Measure,
bifurcation.
that's your bifurcation.
All right. Any
And
thoughts now?
the only advantage of DCB is you can extend it all the way into the CFA.
CFA.
And just GSCB from prox CFA all the way down to your E marker or longer down there and just provide the drug all the way up and down.
Mary,
But-
what's the reference vessel size?
I don't know, you're right. That was
7. We'll go with the 7. then.
a hard
7.
decision.
7 DCB.
7
if the
100.
patient does ever need surgery, it would help
Yeah.
not to have a stent there too.
So Ajit, can you talk about that? Is it very difficult to remove these stents when you're doing surgery?
You can. It just sometimes it creates more inflammation in the vessel, and it can be hard to find that right plane.
Okay.
And this would be tricky because if the vessel rips or anything, then you have to kind of start reimplanting the profunda, doing a little in-position bypass with grafts. So it definitely makes it trickier,
Got it. Wait 1 second.
but it can be done.
I got it.
And it doesn't matter the type of stent, supera versus alluvia?
Not so much that I haven't noticed the difference. Maybe covered versus bare metal. Sometimes the covered comes out a little bit easier, but between bare metal, not much of a difference.
Okay.
Right, let's see if the DCB.
Wait, it's not down yet.
One sec.
It's not down yet. Little die, guys?
Die?
Yeah, we got to go
Can
way
I
down.
can I just come off here? Yeah.
Why are you holding the DCB? Just hold it
No,
up.
I just
Yeah.
remove.
Okay. Okay. Little die. Yep. All right, let's go up.
So one
I'm
of the
not going to wire predict here.
exactly. That was one of the questions they had asked is like, would you put a wire down just
Hold
in
on.
case
Let's
because you're-
decide. All right. You want to just give me a give me
I
a
don't
No.
give me actually.
It's just a
No, we
question.
didn't go.
It's
We
a
didn't
good
go up
question
yet.
to
Though.
ask,
We didn't
yeah.
go up. So give me the run through.
I would say if it didn't do anything with the lithotripsy, we're not going
lithotripsy
on
and
high
this,
pressure
or-
here.
Yes.
Probably
Okay.
don't need to.
All right. So let's go up.
But
Plus we have
Buff a little
we have a
bit, buff a
surgeon
little
here.
bit.
but I don't want to be blamed. Vishal also agreed with me.
I agree with you. Don't worry.
And I'm just going to low pressure.
So for everybody at home, we're using a 7.0 Ranger. So the Ranger, as you know, is a paclitaxel coated balloon, has a lot of data associated with it, has
Nominal
been
6.
studied. So its nominal is 6. And as we know that the Jetstream has been studied in the Jet DCB trial. So again, we kind of have a little bit of data
Jet
in this
Ranger,
particular level. So 3-minute inflation. And then we'll decide whether to aspirate or just capture the filter as the next step.
Yeah, I think it's a very good point. Even if whatever devices might claim that they have an aspiration component to it, there's always some distal embolization that does happen for whatever reasons, density of calcification, the degree, and the extent of calcification. So it's always good to have a filter like PK put in right there. So it really helps you in the long run. And we really didn't have good below the knee vessel pictures this time. We had it last time, but seeing the progression of the disease, filter red definitely protects you. And then that'll be another management strategy once we have it.
And this validates our algorithm out of Sinai that we published many years ago
Correct.
now in JACC Interventions, that calcified lesions, nodular calcium, regardless of the size, when you do atherectomy, has to have a filter. I mean, I think it's logical sense. A lot of people don't use filters, but you could see even with the filter, even without Vishal, the filter moved. So I think he has an effect. He has an effect from where he's sitting, and so therefore we're a little concerned about what's going to happen. Karthik was yelling at me for saying that because whenever we say Vishal, the filter moves. But we'll see.
Karthik would always support. So
Absolutely, you know that, Vishal. Yeah.
So it did look like there was some stuff in that filter, right?
Yes,
Yeah,
absolutely.
there's a little bit of stuff.
Would you?
What would you do, Ajit? How would you deal with this? In the surgical OR.
So it depends what it is. In this case, unfortunately, it's like mostly chunks of calcium. So injecting like a little TPA or trying to put a 035 catheter down, I don't think is going to do much. So I might even consider is like putting a thrombectomy device down. As a very, it's an expensive choice, but one option is putting like a penumbra, Liberant, whatever, down into the filter, turn it on, and then partially recollapse it using the thrombectomy device. So I've done that in high-risk cases. But I think the most important point is not to fully collapse it if you can avoid that.
Capture.
Because if you partially recapture it, then hopefully it doesn't.
You can see at the end here, you'll see the filling
defects there.
Right there.
Yeah,
right
there's
there.
a good amount in there. So like I'm definitely worried.
I mean, I don't know. I tend to be a little bit more loose with the filters. I still use them, but over here you have a very clear, opaque stack of contrast that's above the filter, and the basket between the end of the basket and about 14 and a half. That's where you see some of the collection. This one, I would just do a partial capture and just remove the wire, everything with it in one swipe. And I think that we would, it's a little bit cowboyish. I get it.
Oh yeah, I mean,
but
we have
but I'm pretty confident that the majority of the embolic material is there within the filter, not above it.
Yeah, right. I mean, I'm okay with spending some extra money in this case, being conservative, getting my aspiration thrombectomy device down there, because you're right. There's a calcium chunk. The problem is distal embolization. Then we are chasing our tail. You know how we've dealt with distal AT, PT, peroneal, and the opening up is a mess. So I think
the ones that really require a thrombectomy have that full column of no contrast.
I understand.
Above.
You're right. It definitely the amount of embolization matters.
Yeah, exactly. So I don't know, just.
Okay, looks pretty good. I'm gonna leave this alone now. Let's concentrate on distal. All right, let's get we chose, I think our team chose the Liberant. As you can see, look at that. Okay, Liberant.
Oh, yeah.
I mean.
So we're going to go with the Liberant, and then we're going to go down and decide.
No. Might need the
good thing is you have an 8-French system, so you can use bigger host devices. I sometimes just...
Look at that. Ajit agrees with me and Vishal agrees with me. Oh, my God. It's going to rain today.
And then, sorry, the other thing you can do is just turn on the Liberant.
If Raman agrees with me, I'm playing Lotto.
Mega Million.
You could also just turn on the device above the filter and leave it on for a little bit and try to just aspirate it out too, rather than collapsing it and retrieving it.
Yeah.
Karthik, I don't even have to say he always disagrees. The vote is always no, opposite. Do the opposite.
This was good.
All right, guys. So again, just for a little technique for everybody at home that we all follow. As you can see, even though we're all a group, we have different philosophies of doing things, and I don't think anything is right or wrong. So you can see here, the idea here is if you're doing it, don't move the filter. Do it under fluoro. We have a great team here, and then obviously work together. If the black part of the wire or the soft part of the wire comes back, have a little bit of resistance. Hold on. Nope, it's going now. Good.
So the other nice thing is the Liberant has a dilator here, because I do think some other devices would have a hard time tracking over the 4 wire. So we put the dilator on to help with that.
A little higher?
Little higher?
A little higher up for me, just so see what the Liberant is.
And then it's an 8-French device.
Good like that. That's all I want to say.
Yeah.
Rail?
But sometimes what I do is if we don't have this device, any aspirin device, I put an 8 French multi-purpose guide, go down, works phenomenal.
We'll start from here.
And then you can aspirate bar, or whatever French device you have. It's 7 or 6. You can put a multi-purpose guide down and you can get enough. Unless it's distal AT, then it becomes a little bit harder.
Well, so Karthik is walking out the dilator, and then we're just gonna set up the Liberant. Maybe Ajit, you can go over the Liberant a little bit with them.
Yeah. So it comes in for PAD mostly 6, 8, and 12. It's an aspiration device. It has a 2E, so you can either do it over the wire or you can do it without a wire.
Okay.
And then it has a kind of audio feedback. So the slow click means you're in open vessel.
You want to show them up here how to do it?
Yeah, sure.
Yeah, hold on. Ajit has a lot of experience with this, so we'll let him demonstrate this very well.
Yeah. So think they can
Are
see
we
here, but
talking about complications or about talking?
I see how it is.
Oh man!
Really comfy.
Yeah, exactly.
You push me on the filter. I'm coming back. Clicking back.
Fair. Eye for an eye.
All right,
So-
what do you do?
So for this, there's a valve that turns it on and off in the tubing. The device is already on, ready to go. They have regular and boost mode. I like to start with regular mode because I think just minimizes blood loss. And then I'm going to advance it.
So what does
So
this click mean?
So slow click means it's open vessel,
Uh-huh.
so no clot.
No thrombus. Yeah.
Yeah, and that makes sense, right? Because we're still pretty high from the filter. So I'm going to go a little quicker because I know it's not there. And then as I get down to the filter,
There you go.
there's the fast click, so it's engaged in something.
You want to twist it?
And then
So that means it cleared it. Now it's slow again.
correct.
Ah.
So now it's in theory clear.
So you know what you can do now is you can inject through the side port to see how much clot there is.
Yeah, well, you could take the tubing off and
tubing
inject.
off, but we don't need to. I'm just saying you could.
Yeah, we can, just so we don't have to take it all the way out.
I'll hold
And then
it
now
if
it
you
says
want
it's engaged, and now it's open.
So every time it double clicks, you slow down.
Correct.
Okay.
Correct. So you want to focus on where the clot is, so to minimize your blood loss. But now this is all open. We left it on for a couple of seconds. So I think we can take the tubing off
Give a little dye.
and pull this a
Want
little.
to get into the filter a little bit more?
Do you want me to? Can I go in a little more?
I think so.
Here you go. Here's a
All
little dye.
right, we're just gonna go a little farther in
Want
just to get.
turn it too?
Okay, here's the dye.
Okay.
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 So let's take the tubing off and give a little dye.
Yeah.
Just for demonstration purposes.
And then I'm just gonna pull it back so we can get a good picture.
Here you go. So we're just going to put a little roadmap, guys, and a little light injection. You can always overspill this roadmap, Karthik. So we're just going to, you can always spill this even when you do these kind of little maneuvers. So there you go, a little dye. Yeah, there's a lot still in there.
Still in there. Also slow flow though, so, but it looks like it's still in there.
It's fine.
So we might have to go a little
A
farther
little
in.
bit further into the.
Yeah.
Or unless
filter.
we're seeing the calcium shadow of the vessel, that could be
Could
the
be,
other option.
yeah.
But we can do one more pass just to be safe.
No,
What do you guys think? You agree, or
Yeah, I agree. Do one more
Okay.
pass.
we'll do a run.
can we take it
But
off?
do
on
you
that?
think the slow flow is
No, I think it's just the outflow
Native?
issue.
correct?
Yeah.
I know that's what my one concern is more on
Yeah.
outflow issues. The filter now looks pretty much cleared out because you
Okay.
can see
I don't know how
symmetrical
much-
flow in both the vessels.
Can I go
So I
a
think
little
it's
farther?
just
Just pull it out, yeah.
Yeah, I think so.
So show the
I held
demonstration
it.
and leave the catheter down.
Okay, you want to do this part?
Yeah.
'Cause I'm not.
Just
Yeah,
pull the
I got
filter
it.
out for me.
So we're gonna partially collapse it now, and then pull everything out with aspiration on. So that way we're minimizing the risk. So, yep,
That's good
that's
enough.
good. And then just pull everything as a
The
system.
system out. That's
you
it.
just suck the.
That's good.
Yep, as a
Yep.
system. Yep, there you go.
Yep.
Good.
Yeah.
Under aspirations. Can I have some nitro, guys? So I'm going to give nitro.
You can stop it.
Yeah.
What's the cuff pressure? We have a little dampening, obviously, from up top.
160.
160.
Let's see if we
Wanna
got
bleed a
anything in
little
that
bit, be careful.
filter.
Yeah, always. We always bleed back a little bit. Okay, flush forward.
It's just
in that
What's my heart rate? 62? Okay, just a little verapamol. Okay, flush. Flush it down, Ray.
Give me the.
Definitely some stuff in the filter too.
So we
So it
just keep
stayed in there.
flushing. Keep flushing.
Looks good.
I just keep flushing more and more. One more. So obviously we give copious amounts of nitro, so yeah, the blood pressure will drop. Obviously, Reka is here to give a little bit of any sort of vasopressors if we need to. But I think we'll be okay. A little more, fill it again. Yeah, blood pressure dropped quite a bit.
Yeah.
Fill it a little bit. All right, so the blood pressure is low, but we'll take a shot just to make sure that we have flow. So, Cindy? Okay, he's moving a little. Hold on, let him move. Yep.
It's already done.
Okay,
Wow.
good
Pretty
sign.
fast.
That's a good sign. All right.
Yeah,
One more.
What's the cuff, guys? Before we give Neo, I don't really want to give.
It's like
160.
I think
Okay.
it's good.
Okay. Then
Hit it again, please.
Oh yeah.
Flow is great.
Beautiful.
No,
Beautiful
flows
flow.
much
Yeah.
better.
Yeah. So it's a complete difference how significant those lesions were
Oh yeah.
and why he was feeling bad. Okay. DSA here.
I'm like sitting at the same time as I'm injecting. It's pretty fast.
Wow.
Yeah. This is
Wow.
beautiful. Yeah.
That's pretty
Okay.
great.
This is much better than we would hope for.
I'm in 3 vessels.
Now let's just look
great.
at the up top, and then we'll say goodbye. Just want to look at that lesion in a couple of views. I know Raman's saying Re-Ivis. I'm afraid to Re-Ivis because it's probably going to make me.
No, Raman is already by it.
The other way, the other way, the other way, the other way, the other way.
Raman's
No,
like-
it's overlap, but it's overlap here.
The I was put on the
More.
floor.
There you go.
What's your
All right,
legs?
sure. Cindy? All right. So this is, hopefully it'll show a good result and we can move on.
Looks good.
I think very reasonable. I mean, it's not perfect. I mean, I think
flow-
surgical
the flow has
endarterectomy is
changed.
perfect, but this is not a perfect result, but I think pretty good for endo.
Yeah.
And I think, that we had a nice demonstration of calcium modification, IVUS use to decide, the sizing, and then obviously adjunctive therapy using lithotripsy as well as a thrombectomy device to be able to deal with a very complex lesion. Now, so any comments, Karthik, Ajit, and team?
Yeah, no, I agree. I mean, I think in these cases you don't want to go for perfect because you could cause more harm than good. But I think this will definitely create symptom relief. So
And especially since he's a claudicant.
Right.
Yeah.
Profunda reserve.
Yeah, Profunda's
Profunda
great.
looks great. Yeah. The flow
Vishal and
patterns.
Raman, any thoughts?
I mean, just the flow, pretty
Excellent results.
huge difference.
No, I think it came out very well. I mean, the technique, the strategy, the planning, like you said, I was sizing appropriately, which we know is very important in these cases, was a major determinant in addition to, choosing the atherectomy device and everything else. So I think,
And also, I
Great
think choosing
result.
the 8-French sheet was a good idea.
Oh, man.
wow.
Wow,
I
Raman, I'm waiting for you. I'm waiting.
Enough for the month for him, man.
You can go 10. You can go
No,
12.
let's not even go there.
Well, guys, thanks again. We're going to
Thank you.
sign off from the lab. Let you guys sign off for everybody. Thank you.
All right, guys. So once again, here from Mount Sinai, thank you very much for joining us. Today was a little bit more of a comical session, but that's always nice. Getting us ready for the summer. But thanks, PK and Karthik and Dr. Rao for a great case. And we look forward to seeing you again on our final Friday of July, on July 29th. And until then, we sign off. Wish you the absolute best and hope your summer gets off to a wonderful, warm, and safe start. We'll see you
Beautiful.
guys next month.
Take care.
Bye-bye.
Have a good one.